Dear Chair, dear colleagues, my name is Danuta Szirmai and I'm a neurologist resident at Semmelweis University. My vision is to revolutionize the diagnosis and the prognosis of disorders of consciousness, and my mission is to do that by validating and promoting new advanced assessment tools. So I had 4 projects in the last 2 years, 2 of them about the prognosis in disorders of consciousness, and 2 of them were about the diagnosis of disorders of consciousness. And I will start with my prognostic studies. But first of all, what are disorders of consciousness? So these states appear after severe brain injury, and they are the so-called minimally conscious state and the unresponsive wakefulness syndrome. Patients in this state may appear to be wakeful, but they do not show signs of awareness of their surroundings. We call them chronic or prolonged disorders of consciousness if they last for more than a month. And they are relatively rare, probably because of the difficult follow-up of the patients. As our healthcare improves, there are more and more patients who are being treated in this state. Are you sure that he will not recover? These are the really difficult questions that clinicians face who treat these patients, and it's especially hard to answer them, since we know that late recovery can appear in some percentage of the patients even 1 year after the primary brain injury. And this unknown prognosis can either lead to suboptimal treatment of the patient or the unnecessary prolongation of life support. Among several predictive markers, what we can use as a marker is, for example, the clinical measure, the always used coma recovery scale revised, which is a behavioral scale, or we can use EEG measures such as functional connectivity markers, which are calculated from the raw EEG data. So our first project was about assessing the prognostic power of EEG connectivity measures in disorders of consciousness. And our clinical question was if these EEG connectivity measures are better in predicting prognosis in disorders of consciousness than the clinical measures. And our hypothesis was that, yes, they will perform better in prediction. Our results showed that EEG connectivity and network metrics predict well the outcome in this patient population in 78% of the cases, while the clinical scale predicts well the outcome in 76% of the cases, and there was a significant difference between the 2 outcomes. So our primary hypothesis turned out to be true. This is a clinical hypothesis, not a statistical one. And this was published in Helion in 2024 May. So as we turn to our second project after our first one, we wanted to further elucidate which are the EEG methods that are the best for EEG signal analysis in this population. So basically, we widened the scope of our first meta-analysis, and we also included qualitative markers, quantitative markers to the functional connectivity markers. Qualitative markers are the one when the clinician visually assesses the raw EEG and concludes markers. The quantitative markers require a bit more computation, while the functional connectivity markers are the most difficult type in respect of computational methods, but they are less time-consuming and there is less need for human resources in these markers. So our clinical question in this project was, how do these EEG markers perform in the prediction of recovery compared to the clinical scale? And we suppose that in line with our first study, they will perform better than the clinical scale. And we also suppose that the quantitative measures will be better than the visually assessed qualitative markers of the EEG. And by answering these questions, we hope to answer clinical and rehabilitative decision-making and make it easier to communicate the prognosis of the patient with the patient's family. We started from over 8,000 articles, and we finished with 22, and we will have 74 studies to include in the qualitative part of the analysis, so the systematic review part. So these are our primary but preliminary results of the accuracy of the prediction of recovery of the different measures. Our effect measure was the area under curve, and we can see that the AUC of EEG connectivity was 0.78, which means that it correctly diagnoses the outcome in 4 out of 5 patients. The quantitative markers AUC was 76%, while the qualitative was 77%, while the predictive ability of the clinical scale was 71%. There was no significant difference between the subgroups of the EEG measures and the clinical scale, although there is an obvious tendency towards the EEG measures. So what could we conclude from this study is that all of the assessed measures showed at least moderate prognostic ability, so they were above 70%, and that EEG markers seem to be better in prognostication than the clinical scale assessed, the CRSR. However, there was no significant difference between the subgroups and the measures. We still think that 8% of difference in the AUC can mean clinically significant, can be clinically significant. Our hypothesis that stated that quantitative EEG measures perform better than the qualitative one turned out to be false, since we have seen that there is no significant difference between the qualitative and the quantitative EEG markers, and even the qualitative markers outperform the quantitative EEG markers' performance. So what is implication for practice the most important is that if we have the chance to choose between the clinical scale and the EEG, we would suggest the use or the addition of the EEG. And if we have the chance to choose between qualitative EEG markers and quantitative and connectivity markers, then we would still suggest the use of EEG connectivity markers, since we know that the assessment of the qualitative markers required a trained personnel, and it's more time-consuming. What is implication for research, for further research, is that these markers work well alone, but they might work better together, so there is a need for innovation and development of the so-called multivariate models, for example, combine them with machine learning algorithms. So these are my studies about the prognosis, and now I will pass to my studies about the diagnosis in disorders of consciousness. And I will talk about, in further details, about the Hungarian validation study of the coma recovery scale revised. This is a diagnostic accuracy study. We started in 2022 July. So basically, CRSR is the gold standard now all around the world in diagnosing disorders of consciousness. And we know that without the use of this scale, the misdiagnosis of these patients can be as high as 38% when the clinician assesses the patient on a bedside visit without using the scale. So it's really a precise scale in diagnosing the so-called non-obvious conscious behavior, the covered consciousness. The scale was introduced in 2004, and in the last 2 decades it was translated and validated in several European and not European countries as well. So we started our validation study with translating the scale, which is the so-called language validation part of the study process. And now we are at the validation of the scale. We have already started to introduce the scale to physicians and in the neurorehabilitative department, to physiotherapists, and also to specialists in logopedia, and we started to train the participating centers. We have already included 6 centers all around Hungary, and we are on the way to recruit more patients. So these were my studies in the last 2 years. The first one got published, the second and the third are still waiting for submission, and my fourth study took place in Liège, Belgium, where I had the opportunity to join the so-called the coma science group for 3 months on a traineeship, where I was a junior researcher and a PhD student. I participated in several national and international conferences with posters and presentation. We initiated an additional original research study of the prognostic, of the predictive and diagnostic abilities of high-density EEG, and we initiated the protocol for disorders of consciousness with the Department of Psychiatry at Semmelweis University. Thank you very much for your attention.
Thank you so much. Very interesting presentation. My question would be, what can be signs of covert consciousness?
What can be signs of the covert consciousness?
Yes.
So covert consciousness is something that we don't see at the first time when we examine a patient. So basically, the most important thing of the use of the coma recovery scale revised is that we spend at least 20-30 minutes by the bed of the patient and try to do motor assessment and visual assessment and communication assessment with the patient. So there are covert signs of consciousness which are not obvious. So if we tell a patient to move an arm and it's not moving an arm, it doesn't mean that he's not capable of, or he's not thinking of moving the arm. You need time and effort to assess the movement or the intention as well.
This recovery after coma is a real challenge. Yeah. Is it related with the etiology of coma too?
Yes, I just made a slide for you. This is this is data from our second meta-analysis. It's the recovery rate, basic. So the prevalence of recovery in traumatic brain injury and not traumatic brain injury. And it's known from the literature that the recovery rate from traumatic brain injury is higher than from non-traumatic, from anoxic patients, for example. And in here we can see that there is a big difference between the two groups. So there is like 10% of difference in the prevalence of recovery between the two groups. So yes, etiology is a confounder and an important point. Yeah.
Thank you.
Thank you very much. It was a nice presentation. I almost became unconscious when I read the title because it was so far from me. But actually, I have a question that somehow I read that there is a marker which used by the traumatologist for diagnosing commotion, the S100B protein in the circulation, which probably refers to the fact that there was a commotion. Yep. Is it possible that this marker should be or could be used for defining whether the patient will recover or not?
Yeah, it's a really good question because there are so there is a debate which is the best method to predict outcome from disorders of consciousness, and the solution will be probably to combine them all, because they use different kind of proteins and markers from the blood and from the CSF as well, from the unconscious patient, and try to use them as predictive markers, and the performance of them is similar to the EEG and the fMRI data. So yeah, there are some tests.
I have an unfair question. That do you think that it's rather a neuronal or glial function, the recovery?
Well, the neurons do not recover, so they do not regrow, as we know. Now we have some knowledge about the glial recovery, so probably neither of them. There are the newly made connections and the transformation of the brain that makes it possible for that patient to regain consciousness, which is basically for us as seen as being able to communicate or move an arm and so on.
Congratulations, amazing presentation. I have two questions. The first one would be that can you tell me the difference between minimally conscious patients and a non-responsive wakefulness? And the second one would be that since I'm into more MRI research, that do you use fMRI for identifying these kind of states?
Yes. So the difference between an a non-responsive and a minimal conscious state patient can be measured in different scales. But the minimal conscious state patient is able to follow motor command and able to follow with the eyes. This is something that differentiates from the unresponsive wakefulness syndrome patient. A UVS patient, as you can see from the outside, is laying in the bed with the eyes open, but not able to follow anything with the eyes and not able to communicate. This is the difference. And then back to the fMRI data. There are several studies about the usefulness of fMRI, but what is the most interesting is the BCI studies, BCI and fMRI studies. So when a patient is asked in an MR machine to imagine that, for example, they are playing basketball, and then the functional data appears in the motor cortex or wherever, or the supplementary motor cortex mostly, then we can suppose that the patient understood the fact that they have to try to, play basketball, and it differentiates them from unconscious and makes them conscious.
I have questions for both. So, are you connected with neurology or psychiatry? Yeah, as a specialization.
Yes.
Yeah.
Yeah.
You are neurologist.
Neurology, yes.
And you? Psychologist. Congratulations, both.
I was wondering if in the early stage, for example, with minimal consciousness states, there is a better chance for recovering wakefulness, for example. And can we do anything? Is there any data on impacts of different rehabilitation processes? I don't know, putting a television screen or just putting the patient on the ICU with all those noises. Does it make a difference in recovery rates?
As far as we know, no, there is nothing that we can do. There are studies that in the ICU, for example, they make them listen to music, and if that changes the outcome or not, because this is the least that they can do to make them listen to music. And there are some studies showing that there is a change in EEG activity, but there is no change in the outcome, at least in the first measurable months, so 2 months. So no, we don't have it yet.
No drugs or...
There are the drugs that we always use, the dopaminergic drugs for akinetic mutism or unresponsive wakefulness patients, the amantadine, for example. So something that, and it's very useful to give them actually amantadine in the beginning of the states in the ICU, because it makes easier for them the rehabilitation, because maybe it's not a lack of motor system abilities, but the lack of the frontal cortex functioning, and amantadine helps in that cases.
Thank you for the presentation. My first question was regarding to, in your first topic, the outcome is dichotomous, either recover or did not recover.
Yeah.
And you said that the coma scale revisited had an AUC around 70 or something like that.
The first one, yeah, 69.
And the other had a little bit higher.
Yeah.
But my question is, what was so both of these were compared to the same reference test in this case?
No, we took the CRSR as a reference test and we compared them to each other. So
yeah, but the CRSR was compared to what? So it was compared to weighting?
No, it was compared to the EEG connectivity metric. There was not another reference test in this measures. So we calculated the outcome for we had the outcome of the patient, and then we had the raw data actually for the CRSR.
So the raw data was basically waiting and seeing whether the patient recovered or did not recover.
And we had the outcome of the patient if they recovered consciousness or not. And then, yes.
So then that was the reference test, the weighting.
Yes, you can say, of the CRSR, yeah.
And then both of them was compared to that. Okay. Thank you.
That was a great presentation. Thank you for that. I wonder whether you have looked at the post-resuscitation coma group. Back for 10 or a bit more years' time, there was high on the agenda the systematic cooling of these patients. And I wonder that this method can really help in point of view of a neurologist, because this mainly was done by emergency and intensive care physicians, that decreasing the core temperature by 3 plus minus 1 degree can really help the recovery of coma patients or not.
Thank you very much for the question. To be honest, I'm not. I think that, but there are some people who know better than me in the ICU if they are still using cooling of the patient. I've seen in some protocols that they still use it, and so probably it is beneficial because they are European protocols. But about the prognosis of the anoxic patient, something that I know that was studied in our meta-analysis as well, that's the worst prognosis among all the etiologies. So.